Is part of your pathophysiology. Now you went through immunology with Dr. Laskin, and as you gathered that immunological events are quite complex, and they get more and more complex every time you look at the literature. And if there's anything you do not understand, you're more than welcome to come down and visit me into my office, in which case you'll get probably more confused by looking at all of the different posters I've got hanging in my office. So let's take a look at what we're discussing here this morning. So what is inflammation? So inflammation, we're looking at a sequence of physiological events that are going to occur in response to a non-specific agent. Now what are we speaking about here? A non-specific agent. That could be anything, including allergic reactions, physical trauma. We're talking about extremes of cold, extremes of heat. We're talking about burns. It doesn't matter what it is. We're talking about anything that can trigger these events. And it's very important that your body responds to these events, because inflammation is required to neutralize or destroy an offending agent. And if that offending agent is a pathogen, of course, it's very important. We want to be able to get rid of it. We want to restrict tissue damage to the smallest possible area. So if you get a splinter in your finger and you have some bacteria on that splinter, you certainly don't want your kneecap involved. So we want to restrict the damage to that very small area. It alerts the body to the threat of tissue injury. So, okay, we have a problem. We need to take care of this problem. We want to be able to mitigate this threat and clear everything up. And lastly, it prepares this area for healing, because you don't want an open wound, because open wounds invite more problems where you're going to have this ongoing inflammatory reaction. And indeed, there are issues with chronic inflammatory responses. And of course, as we just mentioned, causes can be varied from exogenous to endogenous sources. Now, inflammation has been recognized for thousands of years. In fact, the ancient Egyptians recognized it. They called it shmet, or hot thing. So this papyrus dates back to 1650 BCE. The Egyptians were actually quite advanced for their time in recognizing different types of disorders. They just lacked the technology to be able to deal with many of the disorders. But they did recognize inflammation. They may not have known its sources, but they did recognize it. And as you are probably very well aware, that there are two main types of inflammation, acute and chronic. Acute, by its very nature, is very short-term, involves the hemodynamic changes that are seen within the bloodstream very locally. Exudate formation, and many of you, I'm sure, have experienced things like blisters, swelling, etc. This is your exudate formation, and the presence of granular leukocytes. And now, of course, this will mean that neutrophils are going to come into this area. And that's not to say that other sorts of leukocytes are not involved. They most certainly are. In the case of chronic inflammatory responses, this is persistent, and these sorts of responses could actually last for years. And this usually involves the presence of your non-granular leukocytes, macrophages, lymphocytes, etc., and will result in scarring and or the formation of space-forming masses. So when we're looking at the phases of the inflammatory response, we need to stimulate the cells of the immune system. And that may involve the stimulation of those of the innate immune system and or that of the acquired immune system. Now, of course, if you're just looking at acute inflammatory responses, like I said, list my quintessential getting your finger pricked by a piece of wood, you're probably not going to be bringing in too many T cells or too many B cells. So your acquired immune system may not be acquired. But your mast cells will be involved, your macrophages will be involved, your neutrophils will be involved. So, but you'll get a different type of component of leukocytes involved depending upon the degree of the inflammatory response. You'll get the release of inflammatory mediators. Now, of course, that's going to be very important. The types of mediators involved that are being released will determine what cells are going to be turned on, what cells are going to be showing up. The fact that histamine, the leukotrienes, the prostaglandins, all of these inflammatory mediators have their functions. And they're going to be causing the changes in the blood vessels. They're going to be chemoattractants, chemotactic agents, such as the chemokines, prostaglandins, complement components, and the like, are going to be bringing in cells to an area. Now, the N-formulated peptides are things that are not going to be released by your own cells. The N-formulated peptides are usually bacterial in nature. So these things are going to show up, of course, when the bacteria get into a wound, and your macrophages, your neutrophils, are already going to have receptors present on their surfaces to recognize these things. So the activated immune cells are going to follow chemotactic agents and get into your tissues to clean up the mess, as it were. Then they're going to remove the tissue debris and secrete growth factors that are going to participate in healing. So, pathways, direct stimulation of the monocyte macrophages, neutrophils, mast cells, or complement components. Now, we're going to discuss complement components. Complement components are a series of proteins, and they comprise some 10% of your circulating blood proteins. Very important. Their job is basically to blow holes in invading bacteria. They also form chemoattractant proteins when they become activated. They also do a little trick called opsonization, which means they make things like bacteria and other materials more apt to be phagocytized by things like macrophages and neutrophils. So they're going to be activated as well. They can be activated directly by bacterial surfaces, and we're going to have a discussion about complement a little bit later. And the microorganisms themselves have these materials. We call them PAMPs. And these PAMPs are what we term pathogen-associated molecular patterns, and this is what the leukocytes respond to. The leukocytes, like I said, particularly things like macrophages and neutrophils, but it's not limited to those two cells. A lot of the granulocytic cells also, things like eosinophils and the mast cells, have upon their surfaces different types of receptors that are already there as a part of your innate immune system, that they're going to recognize these things and already be primed to go, hey, I know what these things are, so I know there's a problem, let's go get them. They're also going to recognize things called DAMPs, which are damage-associated molecular patterns, so they already know that, okay, there's tissue debris around, so I've got to go pick that up. IgE may be synthesized. Now, of course, this tends to happen in allergic reactions, and it also tends to happen in the case of helminth types of infections, and those are worms, those are parasites, and those will cause activation of mast cells. We can get direct activation or degranulation of mast cells. Now, mast cells, like I said, are these histaminergic containing cells, and they'll blow their granules out, and they have all sorts of other materials within their granules, as well as producing cytokines and active lipids. And we'll discuss a lot about that shortly as well. synthesis of antibodies, IgM and or IgG. These will involve, of course, your not innate immune system, but your adaptive immune system. So the lymphocytes will be involved here. You'll get complement activation as well as binding of these antibodies to the pathogen. And recognizing of the antigen MHC complexes by the T helper cells. Now I know Dr. Laskin went through this discussion, so I'm not going to spend a lot of time discussing this, but like I said, anytime you have questions on this sort of material, you can, of course, approach her or myself for clarification on this material. So, like I said, leukocytes can be directly stimulated by microbial components because upon their surfaces, they already have receptors that recognize things that are on pathogens, on bacteria. Things like toll-like receptors, things like non-like receptors, things that will recognize lipopolysaccharide and teichoic acid. So all of these things are going to be present in and around the leukocytes, on the leukocytes' surfaces. Lipopolysaccharide itself and teichoic acid will activate not only the complement cascade itself directly, but also the blood clotting cascade. And this is very important because some of these cascades, under normal condition, would require the presence of other materials. The complement cascade was first found to need antibody to be activated. Well, you don't want to have to wait a week or two for antibody to be produced to start this cascade. But it has been found that bacterial products will activate this cascade. Likewise, you don't want to necessarily have to have a severe amount of tissue damage to activate the blood clotting cascade, if indeed you need it. Now indeed, if you have bacteria in your system, chances are you do have tissue damage somewhere, which would already activate this cascade. Now we're going to discuss this as well a little bit later. But these are things that will directly activate leukocytes. Okay, so let's start off with acute inflammatory responses. Very rapid onset, could be minutes, seconds, and relatively short duration. So short duration could be, like we said, minutes, or it could be a few days. And what we're looking at is something where you're going to have some inflammation, some exudation of fluid, some edema. You're going to have the neutrophils probably coming in from the bloodstream as far as the immigration of leukocytes. Now, with that being said, neutrophils are not going to be the only cells involved. You have to remember, anytime there's tissue damage, any resident immune system cell is going to be involved. And when you're looking at tissue, all tissues have resident macrophages, and most tissues have resident mast cells. And most tissues have some resident lymphocytes floating around. I can't say floating around, they're in the tissues, usually in a lymphoid mass someplace. So there's always the potential, no matter where you have some damage, you're going to get more than one population of these cells involved, even in acute inflammatory responses. However, when we're talking about immigration of cells from the blood, we are talking about neutrophilic inflammation, neutrophilic immigration. Neutrophils do not normally live in blood tissues. So if we look at the cardinal signs of inflammation, it's heat, redness, swelling, and pain. They were first described by Celsus in 30 BCE. Virchow, in the early part of the 20th century, added loss of function to these cardinal signs. And I can see you scratching your head and say, okay, Dr. Gardner, if I get a splinter in my finger, I'm clearly not going to be on crutches. So what the heck is the loss of function? Well, you've lost the function of that little bit of skin through which that splinter has gone. And you've lost the function of perhaps the blood vessel that has been pierced by that splinter. So it doesn't mean you have to be on crutches or have your arm in a sling if you have had some damage or have had some inflammatory response. But there is some loss of function someplace within that part of the damage. So as we look at the acute inflammation and the symptoms, there are a number of different physiological responses that occur. Things from release of the mediators from the cells, vasodilation occurs, increased blood flow into an area, extravasation of fluid because of the permeability of the endothelial layer of the blood vessels, cellular influx. Remember what we said, we're going to have mostly neutrophils coming in. If the problem persists, we'll get monocytes later, and elevated cellular metabolism. And if we look at what these things bring in, the heat is caused by the increased blood flow to the area and the increased cellular metabolism. Vasodilation and the increased blood flow are responsible for the redness. The swelling is due to the vasodilation, the vascular permeability, cellular influx, and the elevated cellular metabolism. And your pain is due to these inflammatory mediators, chemotaxis of cells into the area, and the increased cellular metabolism. So what happens? So the first stage in the inflammatory response is a vascular one, where you get an increased blood flow due to the arterial dilation. Now, what happens when you have arterial dilation is you actually will have a slowing of the blood flow. Now, I want you to wrap your head around this. I'm telling you there's increased blood flow to the area. So you've got vasodilation, and the flow of blood through the area is going to slow. Okay? Now, concept. Think of a green garden hose. You have a green garden hose, and you've got a flow going through the green garden hose. If you put your finger over the green garden hose, restricting the flow, what happens? It increases, right? Take your finger away, the diameter increases, and the flow is lessened. So same concept. You have vasodilation here. You have more blood going through, but it is at a slower rate. So we have the increased blood flow going in. We have the expansion of the capillary bed, and with the increased the expansion of the capillary bed, you actually will have the endothelial layer beginning to come apart somewhat, allowing for the extravasation of fluid and ultimately the immigration of neutrophils responding to whatever is going on in this area as far as tissue damage and or bacteria. Now, what would happen in the triple response is you get a thin red line, followed by a flush, followed by a wheal, which indicates the edema. Now, this is where I would usually do my little, I say, party trick. And you could do this at home. You just take your thumbnail and scratch your inner arm, and I will apologize if I have to put this down over my arm. You scratch the inner surface of your arm. Within a few seconds, you'll start to see the red line forming. That red line is the first stage of your triple response, which will be the vasodilation of the capillaries. And probably within the next 30 to 60 seconds, you'll start to see the flush, which is the vasodilation of the arterioles, shortly after this initial damage. Now, mind you, I never get to the point where I damage my skin and nose.